Hello everyone, welcome to the EUROGEN webinar series. I'm Michelle Batty and I'm the manager of the European reference network that we call EUROGEN. EUROGEN is one of 24 European reference networks, all created and funded by the European Commission since 2017. And they all deal with patients with rare diseases or complex conditions that all require highly specialised healthcare. And in our case, we're a surgical ERN. So all of our partners are dealing with highly specialised surgery. At the moment, we're a network of 56 healthcare providers in 20 member states. And what do we aim to do? Well, we aim to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So we do many activities together, and one of them I really would like to highlight is we have a fantastic new tool called the Clinical Patient Management 2.0, and it has been recently updated by the European Commission and IBM. So we would love to try it with you. If you're a clinician treating a patient with one of the diseases which falls within the scope of our network, and you can check that on our website, please get in touch with us via our website. We can arrange a cross-border virtual consultation with a number of our experts. So please, we're hoping to have at least 1 or 2 cases before Christmas. If you're in the EU, please get in touch because this service is completely free. We also work together collaboratively on clinical patient guidelines, and that's the topic of this evening's webinar. We've recently produced collectively across the ERN the EUROGEN guidelines for anorectal malformations, an overview and clinical impact. So the presenters here this evening, and I really would like to thank them for the enormous amount of work that's really been put into this cross-European guideline. We have Dr. Jan-Hendrik Gosemann. He is a paediatric surgeon, a deputy head at the Department of Pediatric Surgery, University of Leipzig, and he has been the guideline chair for ERN EUROGEN Clinical Practice Guideline on Anorectal Malformations. We also have Dr. Ramon Gorter, and he is also a paediatric surgeon and principal investigator at the Amsterdam Pediatric Abdominal Center, Emma Children's Hospital, Amsterdam UMC in the Netherlands, and his research interests are rare and complex gastrointestinal disorders in children. And then finally we have Willemijn Irvine, and she works at Qualicura and the Department of Pediatric Surgery at the Erasmus Medical Center, Sophia Children's Hospital. She's been very kindly supporting all of our experts. She's a methodologist, and her interests are the optimal methodological strategies for the quality improvement and guideline development in rare diseases. So without further ado, I'd like to hand over to our presenters, and they will go through in detail the development of the guideline and, more importantly, the important things that it tells us about improving patient care. Thank you. I hope you enjoy the webinar.
Great. So thank you, first of all, Darren, and also Michelle. I hope you have a safe travels, for inviting me, Jan, and Willemijn to discuss, I think, an important topic that we recently published, the ARM guidelines. So as mentioned, I'm a pediatric surgeon at the Emma Children's Hospital, and I have no conflict of interest. So just as a short background, and I think we all know, is that we developed guidelines on anorectal malformation. And that is a group of rare and complex congenital malformation, which is mainly characterized as a developmental disorder. And a recently nice paper from the Blau showed that there is an overall prevalence of about 3 per 10,000 pregnancies, or 2 to 6 per 10,000 live births. So it's really can be seen and categorized as a rare disease. And what's more important also in this group of malformations is that it's often a complex and difficult disease to treat, not only by the disease itself, but also because it's frequently associated with additional anomalies. And it's either within the factor L, which is being reported in up to 20 to 50% of the patients, depending on the paper you read. And also it has been associated with several syndromes that you can see here in the table in about 10 to 20% of the patients. And I think we all know it's a spectrum of disease. So it entails many types of anorectal malformation. And I think that the classification system that is often used is the Qualicura classification. And you can divide them into more common types of ARM and into more rare types of ARM. And here on the slide in the table, that's also from the recently published paper in Nature, you see that especially rectoperineal and rectovestibular in males and females are the most common types. But there are also more rare types like rectal bladder neck or cloaca malformations. And these types not only have an influence on prognosis, but also on the chance of associated anomalies. And this is just a schematic overview of all types of anorectal malformations within females and males that we are treating as a multidisciplinary team most often. And you can see that it's not only a problem sometimes with the hindgut, within the hindgut development, but I always say that there's also a problem within the whole development of the pelvic system. So if you look at the overall prevalence or the incidence that has been reported and we accounted for Europe, we know that in Europe in 2023, about more than 3.5 million babies were born. And if you put the numbers on anorectal malformation and its prevalence on these numbers, we can estimate that there are about 700 to 1,250 children born with an ARM through the whole of Europe, which means that the actual caseload can be quite low. And again, it's challenging due to the associated anomalies. You often need a multidisciplinary team, but also is that this disease is associated with long-term sequelae. And I think we are already trying our best to get more experience and to share knowledge within on this disease within our networks. Of course, the eUROGEN networks that has already been introduced by Michelle, but also the ARMNet networks and also other networks within the world are trying to mobilize and to take the care of these children to the next level. But again, it's still challenging. And I just want to make this clear through just some 3 topics on which we recently had discussion. This is a child, a boy that was transferred to our hospital. He was born full term with about 39 weeks. Antenatally, there were no abnormalities noted. And on clinical examination, we didn't see an anal opening on the perineum, nor did we see any black ribbon or meconium discharge from the meatus. So he was transferred to our clinic. And I think that we had a lot of discussions, as we always have within our clinic. And these are just 3 points, 3 points I would like to make. So the first is on the factor L analysis. So there are some clinicians that prefer ultrasound, others prefer to do an MRI for spinal cord anomaly. And I think this is also highlighted in the recently published paper from the PCPLC, the consortium from the US, in which they analyzed the screening for spinal cord dysrhythms in more than 900 patients. And you can see here in the chart that there's still a great clinical practice variation on whether they will do an MRI only, whether they will do nothing at all, or only an MRI or only an ultrasound. And it's not only for the diagnostic workup that there are still knowledge gaps or discussions going on, also for the treatment. So with this boy, there was an indication for decompression by colostomy placement. And I think that we were all historically learned and taught by the group of Peña that the ideal or the preferred method would be a split or a divided colostomy on the descendens sigmoid junction. Was the way to go, was the recommended colostomy placement in earlier days. And that was done so we can divert the fecal stream, we could prevent a urinary tract infection, prevent the megasigmoid or megarectum developments. We had to make sure that there was no interference with reconstructive surgery. And also because it was at the junction, there was a prevention of stomal prolapse. But then if we look at how we are actually, what type of stomas we are actually doing, this is a study from the ARMNet consortium, in which they analyzed more than 2,500 patients from 34 countries, in which there were over 1,000 patients. A stoma was created. And you can see here that not all patients get a divided or a divided colostomy as we were treated. That was only been done in about 3 out of the 4 patients. Well, 1 of the 4 patients would get a loop. So what's then the way to go? So what's then the ideal stoma in these patients? And lastly, as a point of discussion, is the fact that what is the optimal perioperative regime with respect to the timing of the reconstruction, mechanical bowel preparation, antibiotic prophylaxis, postoperative feeding regimen. So this is a paper from the group, also from the ARMNet consortium, that has been published in 2019 already. And as you can see here, in this study, there was a lot of clinical practice variation. So there were clinics that were giving less than 24 hours of antibiotic prophylaxis, about 1/3 of the clinics, while the others would give prolonged prophylaxis for more than 48 hours in 2/3 of the patients. And also, if you look at the postoperative feeding regimen at that time, there were in 1/3 immediate oral feeds, but in 2/3 nil per mouth. So still a lot of clinical practice variation across the centers in ARMNet consortium, but also I think worldwide. And I think that this can be partly explained by the fact that if you go in the literature, that high quality evidence is lacking. And this is just a screenshot from the PubMed search that I performed just formal on anorectal malformations. And if you look at all the research, there are more than 3,000 papers published, and you see that in the last couple of years, there's a large increase in the papers published on anorectal malformation. But then let's see what is the highest level of evidence. And I think we all regard, or we all think that RCTs at this point are considered to be the highest quality of evidence there is. But only 17 RCTs have been published in these in the research for anorectal malformation. So challenges, and that is why I think that particularly in rare diseases, guidelines can be helpful when high quality evidence is lacking. And in that way, we are able to combine evidence with experience. And I think that Willemijn will discuss in her paper more about the robust methodology that we created to integrate the available evidence there is with the experience there's also is, because we need to also take that into account. And we hope that with these guidelines, we can reduce clinical practice variation, improve outcomes for patients, but we also need to make sure that there are still challenges that we need to improve for patients in the future. So these are some of my take-home messages, and I especially wanted to point out that there is still a lot of clinical practice variation with limited high-quality evidence, and that is why I think that guidelines can be very helpful. So I'd like to give the word to Willemijn to discuss the development of the ARM guidelines.
My name is Willemijn. I'm a methodologist, and I also am a PhD candidate. My special interest is developing guidelines, and I have no competing interest for this presentation. And I want to start by telling you something about what a guideline actually is. So this term might be familiar to some, might be very unfamiliar to others, but this is the term that is short for good old boys sitting around the table. And this is a practice that many people still think is how you make a guideline. But we think you should do it differently. Because the issue with this, just talking about your course of care and writing down how you think the care should be, is that it gives a lack of transparency and structured approach, and it doesn't meet standards of trustworthiness as it comes to research. So what actually is a guideline? A guideline is an advisory document that is informed by evidence, so preferably a systematic review and a critical appraisal, but also rigorous assessment of benefits and harms and additional considerations based on the opinions and experience of experts and patients. So how do we develop a guideline? Well, we start with a panel, a group of experts, preferably also patients or patient representatives. And depending on the topic, this should be a multidisciplinary group. So if you're maybe for the topic of ERN, we had predominantly pediatric surgeons and patient representatives. But if we're looking at other topics, such as Hirschsprung's disease, we have also included a dietitian and a pediatric nurse and a gastroenterologist and a histopathologist. But you start with this group of people, and they are starting to talk about the issues that they have with this, with the clinical care of this disease. And then they list and prioritize these items. And you actually start from the point where Ramon just talked about with this patient. So this patient with a malformation is admitted to my clinic. And then what do I do? So what are the issues that I encounter and what are the questions that I have? So the group lists these items and then transfers them into questions. Usually in guidelines, we use the PICO structure, so patient intervention, comparison, and outcome. But in the rare disease guidelines, sometimes you can also make more broader, more explorative questions. Because there simply isn't the knowledge yet to make a strong comparison. So then we're going to look for the best available evidence. And then a very important point is that we appraise this evidence. So we score the trustworthiness of this evidence, and we look at the methodological quality of these studies. And then all this information that you gathered floats back to the panel, and then the panel starts discussions that are structured based on the points that you can see here. So discussing what does the evidence tell us and how reliable is this evidence? What are the benefits and the harms? But what are the values and preferences? So one intervention may perform a little bit better on one outcome, but another intervention may perform better on another outcome. And then which of the outcomes is more important to patients? And then in this context, talking about an outcome, we can, for example, say length of hospital stay, but this can also be the status of continence or the wound infection or things like that. So you look at those type of outcomes, and then you start to weigh like what is most important to my patient group, and how much evidence do we have for that, and how much experience and what can we share from what our experts know and see in their clinics. And then there's two other things that is very important to include in the guideline development, which is the feasibility and the acceptability. So in the feasibility, you're mostly talking about do we have the means and the tools to practice certain types of care. So if we're making a European guideline, we want to issue recommendations that are feasible for most of the countries, and that maybe some other countries can use the guideline to get access to this type of care. For example, new methods of genetic testing. But then also we have to talk about the acceptability. So how likely is it that if we advise this in our guideline, that people are actually going to accept this and are going to be willing to follow it? And I think an example for that is that a lot of types of care are also embedded in the culture. So if you recommend something that is not leaning on very strong evidence, but that goes strongly against a cultural practice that we have in many European countries, then you can expect issues with the acceptability. So, and then based on a mix of all these items, the panel makes a recommendation, and this can be a strong recommendation or a conditional one. And a conditional recommendation can either be well, we suggest this because we think it's a good option, but we are not really sure. but also conditional recommendation could be that you suggest it because you believe that it's very good for many patients, but not for all of the group. So then it becomes more of a subgroup consideration. But we have challenges if we do this for rare disease, because the typical guideline methodologies, they are really evidence-based, and they lean on high quality evidence. And what we have here is little evidence and low quality evidence. So like Ramon showed in his talk, for ARM, there are very few RCTs. So we have to work with more observational evidence, which can be a challenge because you cannot be so sure about causality all the time. And then another issue that we have particularly seen in the ARM research and populations is a lot of heterogeneity in the outcomes, but also in outcome definitions. So people don't register the same outcomes in their research, but also the definitions they use for the outcomes are either different or even unclear. So what we do to mitigate this a little bit in the rare disease projects is that we search for the best available evidence. So where guideline developers making a guideline on diabetes or breast cancer may set the bar to only include systematic reviews of high quality RCTs, we are including everything that we can find up to a certain level that we discuss upfront. So for example, for the ARM guideline, we decided we are including observational studies if they include more than 10 patients. And then the other thing is that we do is that we look at the strengths and weaknesses of the study within the design. So yes, an observational study is sometimes less sure or giving less sure conclusions compared to an RCT. But if the observational study is performed really well and the methodological quality is high, then sometimes it can still give a lot of good information. And for the heterogeneity, this often prevents us from pooling the results and making a numeric effect estimate. So what we did instead is we used descriptive forms of evidence synthesis, and we summarize the evidence, and then we ask the experts to interpret. So what does this mean? And does this give us any information about the direction of our recommendation? So then, after I've introduced you to how we make a guideline and what actually is a guideline, then there is the next thing, because the goal of the guidelines is to reduce practice variation and increase the quality of care. But once you have a guideline published, it doesn't equal that you have recommendations on everything, and it doesn't equal that you have high quality care, because the guideline you have to see as only a part of quality improvement. So this figure is designed for ERN Ernica, and I was one of the authors on this piece. And what we try to do here is piece everything together and see how guidelines and implementation and measuring can follow each other up in a cyclical way. And I want to talk about a little bit with you, especially here on the top left of the figure, where you see that there is an exchange between research and described quality of care. So while we are making guidelines, sometimes we don't have the evidence. And then if we look at the experiences of experts, and we are listing this on all these items that we discussed, sometimes it's not so easy to make a recommendation for one thing over the other. And then you have to acknowledge that this is a knowledge gap, and that this could be a priority for further research. And then the next time that you revise the guideline or update it in a few years, maybe you have new information from research that you can feed back into the guidelines. So it actually becomes like a knowledge loop. So where we started is with describing quality of care. And for the ERM, there was a guideline, a Dutch quality standard, but it wasn't made for the European setting. So what we did is called guideline adaptation, which is a systematic approach to evaluate and modify clinical practice guidelines that are developed in one setting so they can effectively be used in other settings. This is something that we can do to decrease the workload that we have, but also to make use of everything that there is, so there's no research waste, so to say. So this is the systematic approach that we use for the ERM guidelines. It's called the ADAPT method, and there are a few important steps here, and I can talk you through it. So first is a consistency assessment. Based on that, you decide, am I going to reject this guideline or this set of recommendations, or do I accept them for adaptation? And the consistency assessment has a lot to do with, does this guideline meet our standards of trustworthiness? So can we trust what's in there? So then say we accepted the guideline or the set of recommendations, then we have to choose if the recommendations we want to adopt as a whole. So then you can do either specific ones or all of them, or we want to adapt. So if we adapt them, we can either update them or adapt them to the context. So from a Dutch context, in this case, to a European context. So the consistency assessment, the judgment to see if this is in line with our standards of trustworthiness, we do with the Agree To, which is a scoring model for the methodological quality of guidelines. And what we found in the Dutch quality standard is that the score on methodological rigor was a little bit lower. And the transparency of reporting was also a little bit lower. And this mainly had to do with that they did a systematic search, but it wasn't always clear what evidence was used for what recommendations. And some recommendations were set apart, but there were also a lot of recommendations that were woven into the main text, which is not meeting the criteria for transparency of reporting. So what we did to improve this is we agreed to make a separate table with all the recommendations and assign a level of evidence to each recommendation. So it would be clear what type of evidence would be underneath this statement. And to improve the transparency and the reporting quality, we used to write ADAPT reporting guidelines, which is made by the same group as the PRISMA guidelines for systematic reviews, for example, but then in this case for adapted guidelines. So then we have accuracy assessment. The main question in this is this guideline based on the best available and most recent evidence? So the Dutch quality standard dated from 2017, or the search strategy. And we started our guideline adaptation process in 2023. So what we did is we updated the search and we made the same systematic search, but only between the endpoints of the search from the Dutch quality standard and the current time that we were living in. So then after this, you have 3 options for recommendations. So if you did all these assessments, you can say, well, I think the quality of the guideline is good enough, and there is no new research, or there maybe is new research, but it doesn't change how this recommendation is stated or how this quality of care is described. So this we would call adopt. So you just take it and you implement it in your new context. The second one is that you say we make a new recommendation because we found in our new literature, or while discussing with our panel our new context, we found things that are not covered by the previous guideline, but we do think it's important. And the third one is that you say, well, we think the old recommendations are partially true, but we also think that we need to make some changes because it's not fully implementable in a European context. And this is something that happened a lot in the ARM guideline. For example, we had the Dutch quality standard also talking a lot about the organization of care, but the recommendations were made based on the Dutch system, where we have the pediatric surgical university centers, and then you have the centers outside that you can have for shared care. And there was a lot of recommendations that were leaning on this type of system, but not all countries in Europe have this type of system. So we had to look at, so what is the key takeaway from this recommendation, and how can we phrase this in such a way that is useful for people in other countries too. So if we are making adaptations to the context, then we are looking at the applicability, defined as to what extent are users able to put a recommendation into practice. And then we're talking about knowledge, skills, and the time available, equipment, but also other resources. Could also be money or insurance policies. And then we also talk about the acceptability. So how likely is it that people adhere to this recommendation? And with this, we discuss internal qualities such as the clarity and the comprehensiveness of a recommendation, but we also discuss implications of this recommendation. So the burden of care for patients and providers, the attitudes and their beliefs and preferences. So how does this process go? So we have structured discussions with our panel, in which we work down a list of things that have to be discussed and have to be weighed before we make a decision. So we start with the current recommendation, and then we look at the new evidence that we retrieved from the updated search. And there was a discussion within the panel for each piece of evidence that we retrieved. What does this tell us? What is the quality of this evidence? And how does this impact the recommendations that we make? So this is an example of how we presented the evidence to our panel. So we had a very short summary, type of study, and number of patients, some results, some conclusions, patient population. And in this way, we screened every new piece of evidence that we found that was included to see if it could possibly change the course of care as was described, or if it would give us new insights. And then if we were to consider changing a recommendation based on new evidence, then of course the full text was discussed with the panel, and we saw if we had to make any changes based on that. So after discussing the evidence and looking at the current recommendations, so then we know, does the evidence change our recommendation or not? Then we discuss the acceptability and applicability. Then we made a decision for each recommendation. So is it going to be an adopt, or do we need to formulate something new? And then after that, we had a discussion about the wording of recommendation. And last, we had a discussion about acknowledgement of knowledge gaps. So as to this topic, are there any things that we just can't say from our experience or from evidence, and that we have to issue as a knowledge gap? So with this, my information is coming to an end, and I can imagine that you start to wonder, so what actually is in this guideline? And that is what Jan is going to tell you.
So the initiative was 2021, and the European guideline on the management of anorectal malformation was the task. So as Willemijn already described, we had a very good blueprint, the quality standard from the Netherlands, which was actually released in 2020. And as you can see, there was already a huge working group of 8 and an advisory group of 15 and multidisciplinary experts of 21. And the guideline or the quality standard itself resulted in a 148 pages of work. And this is an elaborated quality standard for the Netherlands. So however, the task was to transfer this to the European level, and Willemijn already said what are the issues there. So the quality standard, which is for in the Netherlands, might be difficult to implement in other countries which have different resources. So we accepted this challenge, and as you learned, we need a working group, and the working group consisted of Ivo de Blauw from Nijmegen, Martin Lacher, and myself from Leipzig, from the healthcare provider side, and we included patient representative such as Dalia Aminov, who everybody might know from Italy, and Nicole Schwarzer, who is the representative of the German patient community. We then created a multidisciplinary panel, and as you can see on the right, we included experts from mainly eUROGEN, and most of the experts are also in the ERN Ernica. The chairs you already know, and the patient representatives I mentioned, but main important was that we have a methodologist, and we had Willemijn and Konstantinos who helped us really getting through this jungle of the ERN toolkit for clinical practice guidelines, which Willemijn just tried to describe to you in a very brief and nice way. So this toolkit is actually for creating new guidelines, but also for the adaptation process of already existing guidelines. So first of all, we had a look at the guideline itself. It was divided in 7 sections, and we decided to summarize these sections in 4 sections for a better overview. So the European guideline now consists of 4 sections, which includes diagnostics, treatment of anorectal malformations, then lifelong follow-up and transition of care, as well as organization of care and communication between providers. We already saw this ADAPT method, and we went through all of these steps: update of literature, search, summarize and categorize the new literature. Willemijn showed you how this was done. We assessed the recommendations and included the studies, and then we decided whether to adopt, adapt, or even have new recommendations based on evidence or opinion of experts. So we needed 17 meetings online for this until we went through this whole process, and we had this expert panel meetings, as you can see in the schedule, and then this finally ended up in the 2-day face-to-face meeting. And you might say these are the good old boys sitting together, but you see there are also lots of girls sitting together here. So we had this pressure cooker, as Willemijn used to say, to this meeting, and we locked ourselves into this room until the guideline was finally discussed and ready to wrap up. So again, the sections I already showed you, and I will go through these 4 sections very briefly. And as you can imagine, we won't have enough time to go into detail to these through these sections, but I will give you a brief overview. And for those, and I hope all of you are interested in the details, I put this QR code on the lower right side of the slide, so you can have the free access to the paper and go into detail and hopefully discuss in the future to improve these guidelines even more. So for diagnostics, I can show you this figure. For every section, we made a figure like this, compiling all the key recommendations for this section. And the key messages for the diagnostics part are that early and accurate diagnosis of anorectal malformations is critical, and even prenatal ultrasound and MRI might be used for prenatal diagnosis. We can discuss this later, but mainly postnatal inspection is important to have an accurate diagnosis after birth, and you have the the right diagnosis according to the Crick and Bed criteria. So systematic neonatal screening for associated anomalies such as spinal, renal, and genetic is essential, as you might imagine, but everybody who's not too familiar with anorectal malformations might not even know that there are spinal, renal, or genetic anomalies in patients with ARM. So we found it's very important as a key message. Multidisciplinary lifelong follow-up supports better functional and reproductive outcomes. And here's a key message, which is actually true for all of these sections. Many recommendations are expert-based. So we need more high-quality research, and I will come to this in my conclusion again. Let's have a look at the treatment part. Again, the QR code, you can scan and free access the manuscript. And this is a summary of the treatment recommendations pre-surgery, during surgery, post-surgery, and continence, and regarding the self-management of the patients. The key messages are, we recommend that complex ARM cases such as cloaca should be referred to a specialized center for expert and multidisciplinary care. The surgery should be tailored to the patient, but also the surgeon's expertise is important, since we know that there's no single preferred technique. There's no superiority of one of the techniques. Furthermore, we should avoid routine painful calibrations and dilatations. And if dilatations or calibrations are needed, it should only be used with caution. And we had a very nice discussion on this topic at last week's meeting in Stockholm, the colorectal meeting. We had a pro and con discussion, and we found out that there's still a lack of evidence stating whether routine calibrations are needed or not. So we need more research to answer this question as well. Family guidance is very important and can be facilitated through education, individualized continence plans, and self-management tools. Which brings us actually to lifelong follow-up and transition of care. Again, the QR code, so you can read the whole paper, and you see that a supervising physician manages the communication to ensure a good lifelong follow-up and transition of care. And that's probably one of the main messages, besides that a lifelong structured follow-up is needed with a multidisciplinary team, and that you need personalized transition plans. And that is really a big topic which we have to tackle in the future. And this should start already in early adolescence, around the age of 12 to 14. We should have an increased focus on quality of life, including mental and sexual health. And we should support patient self-management through education and access to information. Information is mainly given by patient organizations, but also by expert centers. And that's where patients and families should get information. Finally, organization of care. You again see that the supervising physician is the center here. And we said that we should assign a supervising physician and a care coordinator for each patient. And this supervising physician should be best of an expertise center. And we also said that the care, therefore, should be centralized in high-volume ARM expertise centers. And then a big discussion was regarding what is an expertise center, actually. And we agreed on that an expertise center should at least treat 10 patients and reconstructions per year, have 10 reconstructions per year. This is still a matter of discussion, obviously. Focus on shared care and communication between centers and local providers is very important, and we should engage families and patients with clear patient-friendly information and regular patient group meetings. So as you can see, this is only a brief overview of all the 4 sections of this guideline, but I encourage you, please scan these QR codes and read through these guidelines, which are all free in the European Journal of Pediatric Surgery. How do we disseminate this guideline? So we have the website of the ERN eUROGEN, where the guideline process and also the guideline itself is provided. We disseminate via social media on Facebook, Instagram, and LinkedIn. And also this webinar is actually part of the dissemination process. So we can, in the end, say that we accepted the challenge, but have we actually accomplished the mission? And now I actually ask you to please read all these guidelines, try to implement the guidelines in your facilities, and if needed, adopt or adapt the guidelines, and mainly give us the feedback so we can improve the guidelines in the future. And we have a lot of things to do, since we learned there are evidence gaps, we need to define outcome sets. We need to define proper research questions of what has not been answered yet. And we all think altogether that the registry is one of the key steps towards a proper or to properly fill these evidence gaps. So I ask you all to join us and help us to improve the quality of care of patients with anorectal malformations. And therefore, I thank you already for your support and also for your attention. And I'm happy to invite the two others for the panel and answer all your questions.
Okay, thank you. Yeah. Hopefully everyone's coming in there. Great. That's Ramon. Yeah.
Yeah, so so thank you, Jan and Willemijn, for your presentations. And just to give you some time, please type in your questions in the Q&A or let us know that you have any questions. We hope that with these presentations, we were able to show you that there's still a lot of clinical practice variation for children with an anorectal malformation, that we have developed new guidelines through, I think, a robust and very solid methodology with the help of Willemijn. And as Jan showed, we now have many recommendations that we hope that we can now implement. But we are still challenged, or we are still facing challenges, as Jan also discussed, with these evidence gaps. And we would really like to get your feedback on topics that should be updated or discussed within the new guidelines, because I do think that guidelines and the development of guidelines, as Willemijn also showed you, is a cycle in which every couple of years you really need to reevaluate whether or not your guideline is still on topic, if there's new research published. But also, let's take this opportunity to use these guidelines to identify these evidence gaps so that we can start working on the evidence for the next couple of years. So thanks, and please let us know your questions.
Okay, I think we've got a question come through. So if you can see that, if you click on your Q&A buttons as well, you should be able to see the question. Okay.
Yeah, there's a question from Jorge Oliveros, and he's asking to please show again a QR code for the eUROGEN guidelines. Of course, Jan will. Jan, can you share? Yeah, great.
Yeah. Let me just go back. So this is the special issue of the European Journal of Pediatric Surgery. You can enter this via this QR code, and I will go back again to the slide where you have the QR codes for the 4 papers. You will also be able to rewatch this on YouTube, and the QR codes. Perhaps we can even provide the QR codes somewhere in the YouTube link.
Yeah, I was going to say we can do that as well. We can definitely have the description in YouTube as well. We can distribute them elsewhere as well. If you send us your slides, Jan, we can take them off there. That'd be good.
And we also have them on the EUROGEN website. So there we can also get the guidelines from.
So Ecuador. So we have to broaden our guidelines a bit. This is cool.
I think so, yeah. This is very cool. To make a global guideline, that would be very nice.
So if there's no questions so far, I mean, we were discussing before, because Ramon, you were giving a few examples on how difficult it actually is to have a proper recommendation from a guideline. So when we look at your talk and your case, the type of colostomy was for example discussed. Yeah. And there in our guideline, we even had a new recommendation stating that the type of colostomy, there's no evidence for superiority between either loop or versus split colostomy. So descending sigmoid stoma is preferred, but in some cases, cloacal malformations or associated gastrointestinal anomalies, a transverse stoma might be an option. And this is a statement which was consented after, I would say, 1 or 2 hour discussion of the expert panel without any strong evidence, I would say. So this just reflects on how difficult it was to find a nice way of giving a recommendation which actually is implementable for the whole Europe, right? And where we have no good evidence. And that's the future goal, I guess, where we have to create the evidence. And that's what I just said with the research questions and the outcome measures we have to define. because without proper outcome measures, as Willemijn said, we can't really define outcome properly.
Yeah, Jan, I totally agree. I totally agree, and that's what I think is that this is also a good opportunity for us as pediatric surgeon or the multidisciplinary team of ARM treating children with ARM to unite and to see what is going to be our research agenda and topics that we can use. I see there's also a question from Wout Feits. He's asking about the patient information video and booklets availability.
I can also go there if you want. So
Yeah, sure.
Wout, thank you for listening, and we all know that this is the next step to go, because part of the guideline development is not only the guideline presentation and the guideline development for the expert, but also to make them accessible for patients. And that's the next step we're going, even before we start the process of revising the guidelines in about 5 years. So in the next years, we will have to deal with proper patient information. Even videos are good as they are done in Hirschsprung's disease. Booklets are already available in the national communities via the patient representative groups, but yeah, that's a big task to deal with. But again, for this, it's always good to have a professional help. Alone from the graphical point of view. If you want to make nice figures, it's always good to have somebody on board who helps you.
Okay, so I'll just give people a few more minutes to type in anything else. Just while we're waiting, if I may, just going to remind everybody that this session is accredited. So you will receive a link directly after leaving to fill in the survey. You don't have to fill it in immediately. You will also get an email later on with the link as well. But if you want your accreditation certificate, you will need to complete it within 2 weeks. Also, yeah, well, obviously the session's been recorded. We'll send everybody the YouTube link tomorrow. We'll also make sure these QR codes are distributed everywhere as well. So there'll be no excuses for anybody not to read everything. And also, please do look at our website, excuse me, for future sessions. We do actually have, I think it's in 3 weeks' time, a webinar on the Hirschsprung guideline as well from the ERN side. So to complement this one. So yes.
I would like to thank everybody for listening and hope you attend the next webinars from eUROGEN.
So thank you also from my point of view, and again, please help us improving these guidelines. Read them, implement them, and give us feedback. That's the most important thing to make them even better.
Yeah, I completely agree. Thank you for your attention, and I hope we have given you a good peek into the world of developing guidelines.